Thank you very much for the invitation to talk in this excellent meeting. The subject of my topic is NASH in immune-mediated diseases. So this is going to be my scheme of the talk. And as you all know, and I'm not going to speak too much about this, NAFLD is considered nowadays as the metabolic, as the liver manifestation of the metabolic syndrome. Obesity, type 2 diabetes, dyslipidemia are really frequent in NAFLD and NASH patients. But let me try to explain you how NAFLD can arise beyond the metabolic syndrome. This is very easy for me because this paper has been presented in the previous talk. But this is very important because this is a study that has been made in 40 non-diabetic patients with biopsy-proven NAFLD. And what they did was to assess the insulin resistance in the adipose tissue and also in the liver, and associate this with the macrophage activation also in the periphery, but also in the liver. And what they see is that there exists a clear correlation between insulin resistance in the periphery, in the adipose tissue, and a macrophage activation that does not exist in terms of liver insulin resistance. When they take macrophages from these patients and they mimic the medium where they are in the NAFLD patient with the palmitic acid, they see how this promotes an activation in the macrophages. And it is very interesting how they connect this insulin resistance in the adipose tissue with an activation of macrophages within the liver, as it has been previously shown. And the conclusions of the study are very relevant, in my opinion, because these findings suggest that there is a link between a deranged metabolism in the adipose tissue and activation of hepatic macrophages in patients with NAFLD, possibly in response to free fatty acid overflow and independent, which is very important, of obesity and diabetes. So this lets me explain how NAFLD can arise in a person beyond the metabolic syndrome, independent of diabetes or obesity. And this has been clearly shown in this very nice review that has been published 3 years ago when they speculate about a possible connection between the skin and the liver, and also with a focus on the liver, on the adipose tissue. If you see, the expanded and inflamed adipose tissue would be sending inflammatory signals to the liver, but also to the skin, and this would make like a vicious cycle. And this study is also very recent and explains how, as they share a very common pathogenic mechanisms, both psoriasis and non-alcoholic fatty liver disease, in these reviews that are published mainly in dermatologic journals, they are focusing on the presence of NAFLD in this type of patients. But if you think about it, we could change with no problem NAFLD and put it in the center, because they share a really a lot of pathogenic pathways, both diseases. And this is a topic that it's now a hot topic, if we could say so. But this is this observation, it's been made a decade ago, and here you can see that in this publication a decade ago, they saw that NAFLD is very common among patients with psoriasis, occurring in roughly 47% of patients. And NASH is found approximately in 5 patients, which was seen in this cohort, in this study that was published some years later with a biopsy, which complements this first observation with a liver ultrasound used as diagnosis of NAFLD. Sorry. when we see what is the risk overall in the long term of developing NAFLD, NASH, or cirrhosis in the population with immune-mediated immune diseases, mainly focused on psoriasis and arthritis psoriasica, what we see is that the risk of incident liver disease in patients with psoriasis, psoriatic arthritis, and rheumatoid arthritis is high, but it's highest, incident NAFLD was highest in patients with psoriasis prescribed systemic therapy and psoriatic arthritis with systemic therapy, and the risk of cirrhosis was highest among patients with psoriasis with systemic therapy and psoriasis arthritis without systemic therapy. In this study, what they analyzed were the factors associated with this connection between psoriasis and NAFLD in a population of patients older than 55 years old. This is part of the Rotterdam study. It's a prospective population-based cohort study. NAFLD was diagnosed by liver ultrasound, and what they see is that, again, the prevalence of NAFLD is increased in the psoriasis population, but the psoriasis was significantly associated with NAFLD after adjustment for alcohol consumption, packed years, smoking status, presence of metabolic syndrome, ALT, and psoriasis remained a significant predictor of NAFLD. If you take into account that not only psoriasis is a pro-inflammatory skin disease, but there are other skin diseases that may cause a pro-inflammatory, chronic pro-inflammatory state in patients. You can take a look to this paper published regarding hidradenitis. Hidradenitis has a much higher inflammatory load compared to other skin diseases, and this has been shown in this study where they compare. It's a case control study where they can when the authors compared a population of hidradenitis with a population with psoriasis or other inflammatory skin diseases, and what they saw is that patients with hidradenitis have higher CRP levels and higher lymphocytes, neutrophilicytes, and this, the authors conclude that the inflammatory load was highest in hidradenitis. And taking this into account, this year in my group we decided we could publish this study that was started a couple of days ago, and where we analyzed the prevalence of NAFLD in hidradenitis patients. And what we saw is that, again, NAFLD is clearly more prevalent in hidradenitis patients compared to controls. And NAFLD was significantly higher in this population. And when we analyzed the factors that are related to this strong association in the multivariate logistic analysis, what we saw is that hidradenitis appeared as the strongest risk factor for NAFLD, independent from classic metabolic risk factors. I'm going to move on to different immune-mediated inflammatory diseases. Both psoriasis and hidradenitis are inflammatory, immune-mediated inflammatory diseases. What are these type of IMID diseases? Well, they share common characteristics as that they have an inappropriate immune response characterized by a deregulation of the cytokines that mediates the inflammatory process. They also share a chronic inflammatory damage whose phenotype is going to depend on the targeted cell or tissue that is affected. They also have common susceptibility genes and risk factors, and this justifies that the occurrence of IMIDs in the same individual and also a family aggregation. And finally, they also have similar comorbidities, complications due to the chronic effect of inflammation, and similar response to similar therapies. So, taking into account that IBD, inflammatory bowel disease, is another IMID, let me show you this work that was presented in the DDW this year. What they did was to use this huge database, an informatic database that included data from 26 major integrated US healthcare systems, and this included more than 62 million people. And what they did was to see how was the incidence of NAFLD, NASH, and non-alcoholic cirrhosis in patients with a previous diagnosis of Crohn's disease. Obviously, this has some limitations if we have to take conclusions with this study, because there is an heterogeneity in the diagnosis methods, both for Crohn's disease and both for NASH and NAFLD. But what they see, it's very interesting, because in this large epidemiological study, what they see is that the prevalence of NAFLD, NASH, and non-alcoholic cirrhosis are significantly increasing in Crohn's disease compared to the general population. And when they analyze the factors that are behind this connection, they see that traditional metabolic risk factors for NAFLD also confer risk in Crohn's disease. They did exactly the same with ulcerative colitis, the same study with the same population, and what they see was very similar. They saw that NAFLD, NASH, and non-alcoholic cirrhosis are significantly increased in ulcerative colitis compared to the general population. But this is very interesting. What they describe in ulcerative colitis is that, of course, traditional metabolic risk factors for non-alcoholic fatty liver disease also confer risk in ulcerative colitis, but additional risk appears conveyed by comorbid ulcerative colitis. This is also a study published this year. This study has a more accurate diagnosis method for NAFLD, and this is a study that used the PDFF to diagnose the presence of NAFLD in Crohn's disease. And very interesting, they used two control groups. Which one is the orange one is an internal control group. It's patients that came to the clinics in a gastroenterology unit, but without known non-alcoholic fatty liver disease. And in yellow, this is a control group that came from the Dallas Heart Study. And what they see is that in the Crohn's disease population, the prevalence of NAFLD is significantly increased compared to these two groups. But which is very important, in my opinion, is that, I cannot. In my opinion, is that in lean patients, this prevalence doubles the prevalence in both control groups. And when they combine NAFLD diagnosis by PDFF with FIB4, what they see is that the prevalence of NAFLD with a FIB4 predictor of fibrosis doubles the prevalence in the control group. In this study, what they did was to retrospectively, in a cohort of patients with IBD, they analyzed the risk factors associated with the incidence of NAFLD. NAFLD was again diagnosed with a suboptimal method using the hepatic steatosis index and in the absence of alcohol. And advanced liver fibrosis was diagnosed using the FIB4, and active inflammatory bowel disease was diagnosed using common scores used in the clinics. And what they see is that with a median follow-up of around 3 years, NAFLD incidence rate was 9.1 patients, 100 patients per year, and fibrosis index rate was 0.5. And when they analyze which are the factors that determine these incidence, what they see in red, it's similar risk factors and in the general population, age, presence of diabetes, BMI. But in green, you can see that also factors associated with the IBD determine the presence of this concomitant NAFLD in the IBD population, as is the presence of diagnosis of Crohn's disease, duration of the disease, and an active inflammatory bowel disease. When they analyze this together, the disease activity, duration of IBD, and prior need of surgery are predictors of NAFLD development independently. And if we think about this IMID population, all of you, I guess that you have been thinking during my talk that this population has a need for many different therapies that can affect not only the onset of NAFLD, but also the natural history of the disease. So let me just give you a few slides about this topic. This is a meta-analysis where they analyzed all the different published studies regarding the effect of IBD therapies on NAFLD. They included 7 observational studies with a total of more than 1,000 patients. And what they see is that there was no significant association between the use of common IBD medications and the incidence of NAFLD. If we take a look with methotrexate is commonly used in psoriasis, as you all know. In this meta-analysis, they conclude that there was no clear association between cumulative dose of methotrexate and fibrosis, and as it has been described previously in the talk of Dr. Andrade, there's data that associates methotrexate with steatosis. Data on fibrosis is contradictory, but it is very important that we know that in all these reports of patients under methotrexate, obesity, diabetes, and alcohol use are very commonly underreported. And just let me introduce you to the topic of how can other different therapies that are commonly used in this population can affect non-alcoholic fatty liver disease. One of the most commonly used are anti-TNF alpha therapies. Obviously, TNF alpha is a key cytokine both in IMIDs and in the development and pathogenesis of NAFLD and NASH. This is just an example of many, many papers that have been published during the past years regarding the role of TNF alpha and the inflammatory pathway in this population. In this study that has been recently published, they see how this MAP kinase, the isoform P38 alpha, which is tightly connected to the inflammatory pathway of TNF, its expression is increased in livers of human patients with NAFLD, and in a mouse model, they see how pharmacological P38 alpha inhibitors can prevent NASH in mice. So it is easy to think how are going to affect these anti-TNF alpha therapies in patients with psoriasis in the NASH population. Well, we don't know it for sure. We have very limited data for now, and this is just I will show you a couple of studies. This is a pilot study. They assess the impact of an effective tumor necrosis factor alpha inhibition in arterial intima media thickness in psoriasis, and what they see is that an anti-TNF alpha therapy effective tumor necrosis factor alpha inhibition was found to decrease the IMT in psoriatic patients without irreversible atherosclerotic plaques. TNF alpha inhibitions, therefore, may have a potential benefit on cardiovascular morbidity rate of patients with severe psoriasis, but when we think about what is going on in the liver, we still don't know, but we have, a few years ago was published this study about the effect of etanercept on hepatic fibrosis risk in patients with non-alcoholic fatty liver disease, metabolic syndrome, and psoriasis, and they compared this treatment with PUVA. And what they saw was that etanercept could be more efficacious to reduce the risk of developing hepatic fibrosis than PUVA therapy, and this preventive effect could be related to its anti-inflammatory and glucose homeostatic properties. So I would like to conclude. I think that I did it almost on time. These are my conclusions. Type 2 diabetes and obese patients are main populations at risk of NAFLD. Nevertheless, there are other at-risk populations beyond metabolic syndrome that must be taken into account. Among emerging at-risk populations, accumulating data points to a higher prevalence of NAFLD in different immune-mediated inflammatory diseases. NAFLD and immune-mediated inflammatory diseases share inflammatory pathways and key cytokines as TNF-alpha, and current IMiD therapies targeting these cytokines may have an impact on NAFLD, NASH, and fibrosis that needs to be better addressed. And this is my last slide. Thank you very much.